Good morning. It's a pleasure to be here. I was here last year, and it's nice to see even more faces here in the audience that we can have interacting together as a group. This morning, I wanted to talk a bit about the role of biopsy for kidney masses and for kidney cancer. And this is an area where my talk is easy because we don't have all the answers. And so what I wanted to share with you today is the reasoning behind when we do biopsies and when we choose not to, but also to talk about what may happen in the future as we get a better understanding of kidney cancer. Just to disclose, I have grant funding from the National Institutes of Health and from the Stanford Cancer Institute as my disclosures. But I'll share a personal story of why I got interested in kidney cancer. So this is my grandma, Betty, at my wedding, and 9 years ago she fell. And as a story that is very common in kidney cancer, she had an MRI because she had back pain after her fall. And that MRI showed two renal masses, and I don't know if you can see well on the CT scan projections, but she had large renal masses in both of her kidneys. And at 82, when she fell, this was a big medical choice for her as to what to do. And like many kidney cancer patients, they decided not to do a biopsy for her. They decided to go ahead and do a partial nephrectomy on one of her kidneys as the first treatment. And after her first surgery, when the pathology was reviewed, that first mass that they took out was an oncocytoma, which is a benign growth. And so she had gone through a big operation at 82. She stayed in the hospital. She developed a hernia at her incision site, all for a surgery that wound up removing something that wasn't cancer. So after this, they decided the first tumor wasn't cancer, the other kidney tumor probably is not cancer, and so they watched her over time. They got a CT scan, and they wound up getting these scans every 6 months, and what they found is on the kidney that was remaining with the tumor, they started to see lymph nodes. And so they were worried, well, maybe this other kidney tumor really is cancer. And so she went through a surgery to remove that other kidney tumor. And this turned out, in fact, to be chromophobe renal cell carcinoma, which is a kind of kidney cancer. So in her case, we found two renal masses by accident because she had an MRI when she fell. And it led to two surgeries where one of the masses was cancer and one was not. And wouldn't it be great with biopsy if we could have that information ahead of time? If we could have saved her the operation for the kidney tumor that wasn't cancer, and maybe known about which tumor was cancer at the very beginning. Now, she's a success story. She's alive today, 8 years later, no evidence of disease, and she's doing great. But I'll tell you that every time I see her, she's happy to see me. She calls me her doctor, but she then immediately points out her hernia and the effects of what the surgery did to her body, and now at 89, what that has meant for her. So I'm going to use some of the slides that Sandy showed earlier, which is this is the data from 2013 for the estimates of kidney cancer in the United States. And as you can see, it's one of the top 10 cancers in men and women. And for death from cancer, it's one of the top 10 in men. Not quite on the top 10 list for women. So the challenge for kidney cancer and for kidney cancer research is that this is a common cancer, but it's not common enough to get a lot of the attention that we hear about with cancer research. So breast cancer, prostate cancer, these things get much more of a lobby and an advocacy voice, and I think we can do better there. Now here's the challenge. This is a graph from SEER, and I'm going to talk about SEER a couple of times in my talk, but the National Cancer Institute here in the United States keeps track of cancer. And they've been tracking the incidence of kidney cancer, and this graph goes from 1975 when they first started doing this. And as long as they've been tracking kidney cancer, the incidence of kidney cancer in the United States has been going up. We don't really understand why that is. We have a lot of theories. One of the theories is that we're finding more things by accident, like my grandma, where we have better MRIs and better CT scans, so we find more things in the kidney. But it's not entirely clear that this is really the whole answer to this problem. And this is a clinical problem because we're finding more and more tumors, and the role of biopsy here may become a way that we can differentiate the bad tumors from things that aren't cancer, or from perhaps things that we don't have to be as aggressive with. So here's the other challenge. We're finding more tumors, but what kind of tumors are we finding? And so this is a plot of the size of kidney cancers when they're first diagnosed, again using data from SEER, so national data from the United States. And what you see is the filled-in triangle represents small masses that are 2 to 4 centimeters. And as of 2001, and it's only gotten more prominent since then, these are the most common sized kidney tumors that we find. So we're finding more and more tumors, and we're finding them at a smaller size. What do we do with these? So this is a quote from Bosniak, who's a famous radiologist who did a lot of work on kidney cysts. But basically, this is it's almost like he's Nostradamus here. In 1991, he wrote a paper, so this is 30 years ago now, that said if we look in patients that are over 50, half of them will have an abnormality in their kidney, so a cyst or a small mass. And this just goes along with what we've seen as our CAT scans and our MRIs have gotten better, is we find a lot of these small lesions and it's not clear what they are. All right, to make that matters worse or more challenging for the clinicians, kidney cancer is not one entity. There are a handful of different types of cancer that just happen to arise in the kidney, and that's what makes them all kidney cancer. And what I've shown you up here is what these different cancers look like under the microscope. And I've just put the first most common 6 types up there. And so you can see when they take out a kidney cancer and they give it to a pathologist and they section it and they stain it and then they look at it under the microscope, they use these pictures to say that it's a clear cell tumor or it's a papillary tumor. And the challenge for a biopsy is, can we get that same kind of information in a very small amount of tissue? All right, so if we thought that biopsy was perfect and we were trying to figure out why we would use it, I could imagine ways that kidney biopsy could be useful for the whole spectrum of kidney cancer. So for my grandma, a biopsy could find benign tumors and basically save people from unnecessary medical care. So avoid unnecessary surgery. For a lot of these small cancers that we're finding more of, it would be great if we could use biopsy to find very slow-growing tumors that maybe we could watch. Maybe my grandma at 82, if she had had a 2-centimeter lesion, the doctor could have done a biopsy and said, you know, this is a very slow-growing tumor. It's probably been there for many years. Why don't we just watch it over time? And again, save unnecessary treatment when it's not needed. But biopsy could also find the aggressive cancers. Maybe they're high grade or they're a certain type of cancer that makes us uncomfortable just watching them. And they would hopefully be identified with a biopsy, and then when we do surgery, we feel better about doing surgery for the right reasons and in the right patients. And then for people that have kidney cancer that's spread outside of the kidney, a biopsy might be a way that we could figure out which drug would be the best drug to give first. Dr. Srinivas showed the VHL and HIF proteins and those pathways that are abnormal. And as these new drugs come out, they're targeting specific steps in these pathways. Wouldn't it be great if we could say that it's this particular protein that's abnormal in your cancer, and for people that have cancer like this with this protein abnormality, this drug works best on average. And so for people that have drugs for metastatic cancer with side effects and all the things that go along with it, we would have a better response rate and less likely to be giving people side effects when the drugs aren't working. So this is the pie in the sky. This is the goal, the holy grail, so to speak, of what we could use kidney biopsy for if it worked perfectly. But unfortunately, it doesn't. So here's the historic limitations. And traditionally, if you look at the textbooks and you go back maybe a couple editions in any of the textbooks, they would say that kidney biopsy is not indicated as part of routine care. And the reason is, the kidney's job is to filter blood. This makes sense. This is the role of the kidney, and a kidney actually gets about 20% of the blood that gets pumped out of the heart with every heartbeat goes to the kidney. So if you're going to stick a needle into the kidney to get a piece of tissue, an obvious potential risk is bleeding. And the size of the needle, where you biopsy, how many times you biopsy, all of these things that play into the risks of bleeding. The other thing is targeting the tumor. So how do you aim the needle to get it to the tumor and not injure things that are in the way? So the kidneys are very well protected. They're protected by your ribs. They're surrounded by your lungs, on the right side with your liver and intestines, on the left side your spleen and intestines. And so it becomes a challenge for the radiologist to stick a needle in the right place without injuring something along the way. So another potential risk of a biopsy is that you cause harm to something other than the kidney. There is a concern that if you stick a needle inside of a cancer, that you would spread the cancer, that the biopsy tract where you've placed the needle would be a place where the cancer might spread to, because you've punctured the tumor, you've violated the tumor. And then actually the bottom reason is the reason that most clinicians have chosen not to routinely get biopsy, and that's because either they don't feel like it gets enough tissue to have a reliable diagnosis from the biopsy, or if the pathologist tells them a diagnosis, they don't believe it. So in my grandma's example, if she had had a biopsy of that oncocytoma, the benign tumor, I think many surgeons would have thought, well, what if that's just part of the tumor, and if you looked at a different part of the tumor, you would see cancer? Because these tumors are not homogeneous. And so the question would be, is there a sampling error, a targeting error, so that if you got results back, would you actually believe them and believe them strongly enough that that would help you decide whether or not to operate? So these are the reasons that we haven't been biopsying everybody routinely. But I wanted to go into some of the new data where we've started to look at each of those things in detail. So bleeding. So if you have a biopsy, often they'll use a CAT scan or an ultrasound to guide the needle into the tumor so they know that they're biopsying the correct place. And if you do a CAT scan after you've had a biopsy, you'll see bleeding, some amount of blood around the kidney, in about 85 to 90% of cases. So in other words, the kidney bleeds when you stick a needle in it. The question is, how many of these bleeding episodes are really significant? And by significant, this group that did this research used either that they had to stay in the hospital overnight or that you got a blood transfusion. And it's 1 to 2%. So bleeding is real, but severe bleeding is rare. And so in modern data, maybe bleeding isn't really the reason to not do a biopsy. So the second one was injury to things that are next to the kidney. And so this has also become very rare. So we're getting better at finding these small tumors. We're also getting better at finding ways to get a needle into those tumors because the imaging that we use is better. We have better CAT scans, better ultrasound. And so we're better at hitting the tumor with a needle and avoiding the lung, avoiding the intestines. So it's far less than 1% of patients that have a biopsy that have some kind of injury to something else. And if you're in the lower portion of the kidney away from the lungs, I would say that it's probably less than 1/10 of 1%. It's very uncommon to have something that gets in the way of the needle on the way to the tumor. And then this is the one that I think I try to talk most about, because so many of my patients are very worried, or they've had other physicians that tell them that if there is a biopsy of your tumor, that it may spread the tumor, and that's why we don't do it. And I could wholeheartedly talk about this for my whole time. But if you look at data, there has not been a single case since 1994 of any tumor published in the literature that was spread at the time of biopsy. And if you look at before 1994, there's about 20 published cases of this happening, and where we have pathology data to look back at the type of tumor that spread after a biopsy, they were very unusual variants. So they may have been bladder cancer that can happen in the kidney and not kidney cancer at all, or variants of aggressive kidney cancer like sarcomatoid or sarcoma that can happen in the kidney. So what I would tell you is that yes, this happens, it's been published, it is a risk, but if you look at the percentage, it's far less than 1/100% of patients that have this. And just like any medical treatment, we have to balance the risks and the benefits. Is it better to have the information that we might get from a biopsy with the 1 to 2% risk of bleeding, the less than 1% chance of injury to adjacent structures, and a 1/100th of 1% chance of spreading the cancer? Where do we draw the line of when it's the right thing to do? And now I'll get back to the challenge of, if you had a biopsy and they gave you a result, would you believe it? So I can share this because this is work that I did at UCLA when I was a resident. If you look at the top row, On the left is the tissue that we took a picture of when we did a biopsy. And on the right is the way that the tumor looked when we were able to section the entire tumor. The left we called cancer. The right, when we actually took the kidney out and looked at it in more detail, was an oncocytoma, so benign. And we had a case where it was the flip, where on the biopsy we thought, oh, that looks benign. It's just these little circles of cells that are in that kind of lighter pink area, and it's not those dense pink cells, pink and purple cells that we see in cancer. So in our series where we biopsied about 60 patients in a row that were going to surgery, we found 2 cases where we got it wrong, once where we called it cancer and it was not, once when we called it not cancer and it was, and it was a particular type of cancer where we made this error. So chromophobe kidney cancer like my grandma had and oncocytoma like my grandma had are very hard to differentiate on biopsy. So I want to leave you with the message that biopsy as we do it today is not perfect, and we can show you that there is some doubt when we have a biopsy and a biopsy result. And the real question is when we're going to use it and how we're going to use it. So if you look at data there's a recent article in the Journal of Urology where they looked at 2,500 roughly biopsies that had been published in the literature, and they found out that they got it wrong, either calling it cancer or not having enough tissue to make a definitive diagnosis about 20% of the time. So the flip of that is that 80% of the time a biopsy comes up with information that is accurate and that you could act on with some confidence. So again, we're balancing the risks of the procedure and a procedure that works 80% of the time. And so that it may give you some explanation about why a lot of providers haven't been doing biopsy as part of their routine care. So we just did a study from SEER where we identified everybody who had kidney cancer over the last 10 years, and we just looked back at their medical record and we said, did they get a kidney biopsy? Just to see out in the community how many people actually get a biopsy as part of their treatment. So this really doesn't tell us if the biopsy gave us good information or if it changed the way that they were being managed. We were just looking at who gets them. And so if these are the percentage of patients that had a kidney biopsy in 1 year prior to their diagnosis of kidney cancer. And it's about 20% of most people. And you see right at the end, there's an uptick for patients that had had kidney cancer that had spread outside of their kidney, where more people were getting biopsy. And I think this gets back to Sandy's point where we have these new targeted drugs. And maybe the biopsy is helpful in figuring out which drug to give to which patient. And if you look at who gets it and who doesn't, people who were more likely to get a biopsy were younger, they were male, they had more medical problems, so perhaps they would rather have the biopsy and the risks associated with the biopsy and avoid surgery if they could get some information from the biopsy. They were more likely to have disease outside of the kidney, and then for tumors that were in the kidney, they were smaller, so they were biopsying more smaller tumors. So that's kind of what's happening today and who's getting a biopsy. It's about 1 in 5 people. All right, so who should get a biopsy? So we have a lot of new guidelines for kidney cancer that have been published. The AUA, which is the National Urology Association. The EAU, which is the European Association of Urologists. NCCN is the National Cancer Center Network. And ESMO is a clinical oncology practice. They all basically say that there is a role for biopsy, but they kind of have different ways of hedging. So the AUA says, if you're going to have your tumor frozen and they're already going to be in there to stick a needle in there to freeze the tumor or to burn the tumor in the kidney, while they're there they should do a biopsy because you're already puncturing the tumor with a needle anyway and you're there. You should get that information so we know how to follow you over time. The rest of the group say, well, you should do it if it's going to change your management, if it makes a difference in what you would do. And for some people they said that you shouldn't do them if you have a large tumor and you're going to get treated with surgery anyway, for all the reasons that we talked about earlier, is that we may not believe the results if we got it in a tumor that was 10 centimeters or on the larger side. We would feel uncomfortable leaving that alone. So you leave it now to the geeks, the researchers, right? So there are people that have made computer models. They put all those risks of the procedure into the model. And they take everybody who gets diagnosed with kidney cancer and they run this simulation thousands of times and have the computer come up with when we should use biopsy And also, if we did use biopsy, would we save any money? And so if you follow people over time, biopsy saved about $3,000 a patient in these computer models. So on the average, which obviously when you talk to a kidney cancer patient, everything is about that particular patient and personalized. But if you applied biopsy to everybody, we would likely save money. We would save people surgery they didn't need. We would save people side effects from various treatments. We potentially could save people from having to have CAT scans for following tumors that we didn't operate on that turned out to be benign. So then I'll leave you with the last little thought, which is what are we doing about biopsy in the future? So I'll give you a little window into one of the research projects that we're doing. Actually, Tommy Metzner is in the back row. He's our research coordinator for this project at Stanford. But there's a kidney on the left, and you can see a little colored push pins that we've put into the tumor. There's a yellow, a green, and a blue, where we've taken a piece of the tumor after it was removed in surgery. So for the last 100 patients at Stanford, the kidney comes out, we cut it in half, we biopsy the tumor as if it was a regular biopsy that we would do before, so that we get the best possible chance of getting tissue, send it off to the pathologist. But the reason that we've been doing this is we have a fancy new gadget at Stanford, and it's called the NanoPro. And basically this machine can look at a tiny amount of protein, and it can say if there's abnormal levels of various proteins, and if these proteins have abnormalities, they've been activated, or they're basically showing signs of accumulating in the cancer. The idea for us is because this machine is so sensitive and can find out these levels in very small amounts of tissue, maybe we can do a very small needle biopsy, so minimize the risk of bleeding, and apply this more broadly to everybody who has kidney cancer and have it be a safe way to do a biopsy. And hopefully in the future, and this is years down the road in all reality, but hopefully in the future we can find a signal that's cancer and a signal that's different types of cancer and a signal that's not, so that we can more reliably use biopsy to really guide treatment. So thank you very much for your attention. It was a pleasure to talk, and happy to have any questions. Yes, sir.
Can you at all say, time-wise, I guess I'm trying to, because I remember when I went for my diagnosis, my physician, my urologist, I asked about biopsies, and he said no for some of the reasons you indicated. Is there any way to say how soon, depending on the stage, how soon a biopsy should be done, or if too much time has passed where it's not?
Oh, right. Oh, sure. So the question was, is there a way to know when to do the biopsy? And if you've already started on a treatment path, does it make sense to do a biopsy then? Or is the horse out of the barn, so to speak? Do we miss our window? And again, we don't know the answer. I think if there was a decision point in your clinical care that might be altered by the information provided by a biopsy, it could make sense. If it was a change in your drug for cancer that had spread outside the kidney, or if it was a decision about whether or not to do surgery. But if those decisions really aren't on the horizon, I would tell you that it wouldn't be worth the risks of a biopsy. And I'll just add one other thought. This is, I think, an area that we're going to see some change in very soon, where there are places, Michigan, Cleveland Clinic, a couple places in New York, that have published data on routinely biopsying everybody. I don't know if that's really the answer yet. I think we should be smart about how we apply it. But we're going to learn more information from their experience. And I think soon we're probably going to use biopsy a lot more than we do now as we've gotten better at it. But again, I think it's really a question where we haven't found the right answer yet. Sir.
This NanoPro that you mentioned, that you understand, do you see those changing use of biopsy?
I certainly hope so. I'm optimistic. But this is a research protocol that would take us years because we have to follow these patients over time and see if we can predict what the outcome is for their particular cancer. So it's not something where I would say if you had a biopsy today, you would be benefited by this NanoPro. This, well, yeah, we're lucky at Stanford that we have it. Only a few institutions in the world actually have this instrument, but it's a research instrument. And so right now, we've been using it to try to gather information as opposed to really guide clinical decisions for patients because we don't know how to use it yet. So hopefully 5 years, 10 years down the road, yes, but not quite yet. Sorry.
Correct me, if 50% of us over 50 years old are going to develop, would it make any sense having CAT scans every 3 or 4 years?
Right.
Before it gets to the,
That's a
before you know you've got a problem?
Right, that's a great question. So for those, yeah, so for those that didn't hear, the question was if these masses in the kidney are so common, does it make sense perhaps to have a CAT scan every few years as a way to find these early or to see them change over time? And this might be one case where the medical establishment usually cringes at the CT scanners or body scanners that have popped up in malls and things like that. But this might be a case where that actually might make sense. And if you look at the CEOs of Fortune 500 companies, you know, they do get a lot of these imaging tests. Whether or not that's the right thing to do can be debated. I think the challenge is you have to separate finding out about it from actually doing something about it. Because we will find a lot of things like a cyst that aren't worrisome, and I don't want you to lose sleep over them if we found them. And we might even find a lot of small tumors that aren't really going to affect your life expectancy or ever cause you any trouble. And so I think the challenge is if we did find more of them by doing these routine scans, we have to be really smart about how we act on that information, because we shouldn't be acting on it for everybody. That's clearly going too far. And so I think if I was designing the system, it would be that we just have to use common sense.